I look at the pelvic floor like a trampoline. So imagine if you have a trampoline very overstretched. When you jump on a trampoline, you don't jump that high because it doesn't have this flexibility. If you have the trampoline very loose as well, you jump on a trampoline, you go straight to the floor. So both of them are not functional. They should have the flexibility enough to deload your impact and also put it up.
Hello and welcome. Today we have Celina and Tima with me here, and we will have very interesting and very specific topic of women's health. Tima is obviously my girlfriend, and Tima is a physiotherapist who actually got me in touch with Celina. They are colleagues. Celina works for Disc in Dubai, and she is specialist on helping women with their lady parts, correct?
Yes.
Cool. First thing first, how you got into the physio, why you started, what was the drag, or was it an accident? How it happened?
I can say maybe I born with that. I don't know, but it was like since my 14s, 13s, I wanted to be a physio. Don't ask me why, but I wanted to be a physio, either physio, psychologist, or a speech therapist. But then I had so many reasons to not be speech therapist or psychologist, but I didn't have nothing against physiotherapy, so I ended up on the physiotherapy.
And what were the reasons? Why not?
Why not? Because psychologist was like, I feel too much the other problems. Like, I got curious. I'm okay to. I love to learn how deal with people, how even people deal with each other. But I think I'm gonna take over all the problems to my place. And like, for sure, if I learn later on, maybe it will not be like that because you manage the way to be away from the problems. But I felt like I'm gonna feel that too much. So let
that
me
was stop
for me.
Okay.
And also speech therapist, I got interested, but mainly because I was seeing speech therapist with kids and I love to work with kids. And I also think physiotherapist was coming from there. I not wanted to be physiotherapist to work like with fractures, with trauma. It was not, I got into that and I love it. I ended up feel that I also like to work with this kind of stuff. But when I thought about physiotherapy, it was not that. It was more to work with handicaps and kids especially, and more neurologists, let's say.
Okay. So more into the neurological part.
Neurological part. And when I was imagining my life in my Celina 40s, I was imagining myself working with this kind of persons, which I could say I still enjoy, but life took me to this environment, and things that coming out I found more interested, and then I just went with the flow, let's say, to find this area to be interested.
Okay, so you studied in Portugal?
Yeah.
So straight after high school, you went to, or you already had a medical-oriented high school?
No, I have a scientific high school, which is about biology and chemical and physical, but math as well. Actually, my better part was math, which I never used in the physiotherapy. But like, I think also physiotherapy is a lot about math and think about the way that you solve problems.
Okay, so the problem solving logic.
Logic, yeah. So I think it was my main point.
So it's not like at night, just for the fun of it, you do math problems at home now?
No, I don't even remember I think anything about math, but actually it was like, I always look at the math like a game, like logic and one after each other. Like I was not the kind of person that spends so much time studying and memorizing stuff and names. Even in physiotherapy degree, I was always stronger in this kind of parts of the physiotherapy. I was like the ones that we need to, of course, like learning and the anatomy, and we have so much to memorize. But my strongest parts was like definitely the logic. And,
okay, so logic, connection of the patterns and all of that was way closer for you than just
memorize. Yes, no, even for memorize, I need to understand why this is like this. I never like, okay, let's study like one. This is like good. Why this is? I need to have a logic behind. And I also have more visual memory, so I was never the kind of person to just read and fix on my mind.
Do you know who is Simon Sinek?
Say again?
Simon Sinek.
No.
It is, he's an author and I would say like motivational speaker, but that's not really precise. He's talking a lot about leadership and so on. And he has a book that is called Start With Why. So just reminded me. Because that's his take on things, that we are way more driven into the why behind the things than just what the thing is.
Yeah.
And it's inner circle with why, then outer circle is why something, and then what. Okay, I blanked out here. Anyway, always start with why. Why, how, and what. Yeah.
Okay.
So why, how, and what. Always start with the why and then roll it from there. That's also how we actually learn everything, right?
Yeah.
Because if you know the purpose behind it, then you kind
it's
of
easier
have...
to accept, let's say.
Yeah.
Yes.
So you studied physio.
I studied physio. I got into a private clinic. I was always like working in a private clinic. Before the private clinic, I did an internship in pediatrics, which I love it. It's part of my one of the parts of myself that I still wanted to discover a little bit more. But then when I started working, I went to the private clinic, and it was so hard to find kids, because we have a national healthcare system in Portugal.
Okay, so this was still in Portugal.
Yeah, okay. Everything's still in Portugal. And most of the kids, they are supported by the hospitals and the national service. And the private clinic, they don't go that much. And then I become to have more women. And actually my thesis from the finish of the degree was about women's health. It was about urinary incontinence. So I started to build up a little bit that time, and then the clinical practice put me on my face more this kind of pregnant woman and postnatal. That's why I came into this field. I also like pediatrics, but life didn't gave me this opportunity, let's say. And as I said, I went to the flow and I started studying more and more and more. It was a way that I found to be close to the kids and still helping the kids in another way, because I'm helping the moms. Yes, of course. So
you said two maybe not that familiar words for many people: urinary incontinence. What it is and why we should care about it.
Yeah, so urinary incontinence is any kind of losing, in that case, because it's urinary, it's pee. So any episode of leakage, it's considered a urinary incontinence. Why we should care? Because actually it's not normal. Even people think, it's okay if you carry weights, or it's okay if you were a mom, or it's okay if you are a kid and 8 years old sometimes happen to have one leakage. No, it's not normal. We always need to, even if you figure out that it's simple, it's nothing measure, and we can adjust with the habits, we should not take it as a normal. We should always look into this and think why this happened.
So it's always a signal that we should
should
change something, yeah?
Yeah, at least stop and look to what happened.
When we talk about it, like usually or even me, a couple of years ago, I would just think old people, you know, like, because with the age and, you know, the Pampers for adults and all that. So this is what you're dealing with mostly. It's actually young women, correct?
Yeah. Unfortunately, I'm not dealing a lot with old women because, again, they think it's normal, so they don't look for help. But when it's young people, they feel like, oh my God, I should not pee my pants all the time.
Okay, so let's say after 70, people will be way more likely to just let it slip, and it's like, oh well, it's just me being old, so on, so on,
Exactly,
so on.
yeah.
So they don't
after
seek
50s,
the help.
Let's say, after you...
After 50?
Yeah, after they get into the menopause. They start to having these symptoms more and more and more. I used to say we all born with the same continence, okay? And then we have some episodes in our life that drops our performance in continence, let's say. So we keep the same, and then we have, for example, a baby, and the continence drops. And then our body is so smart, and we still have strength, and the body can recover, and you recover, but you never reached the point that you were before, okay? If you're just talking about trauma, okay? And then you have a second baby, and you go down again, you might be peeing your pants for like 1 month, but then when you go back, you never go back for the same stage again, you go back a little bit lower. And then when you reach the menopause, the hormones and so much going on your body, and there is no way to fight against this, and then the continence drops straight forward.
Wow. Okay, I have so many questions now.
And I have one.
Okay, go on.
I forgot.
Okay, that was quick.
No.
Okay, think about it, and we'll get back to it. Okay, just wait on me. So you said that it's always somehow related or triggered with a trauma.
No. I say that it's not related with the trauma. I say like the trauma is not helping. Okay? But if you are a kind of person that you hold your pee for so long during the day, you are just decreasing your performance as a continent boy.
Really?
Yeah.
Even just by holding too long?
We should listen on our body, and we should go whenever you find the sign. The sign to go to the toilet, it's unconscious sign from our brain. But the way to go, it's you. You are the one that decide if you want to go or if you don't want to go.
Yeah, of course.
But if you do misconnection the connection with your body, let's say, you start just avoiding and not paying attention to these signs. Same that you are hungry. Okay? You like, if you don't eat, maybe your hunger goes away. And then you start losing weight. Let's say.
Yeah, don't tell me about that. Yeah. Okay, so you're telling me that if I'm holding my pee for whatever reason it is, because I'm in traffic, whatever it is, and it's like, let's say, already painful, or not necessarily painful, but like high discomfort, and I'm holding it, that's already a problem, and I shouldn't be doing it too often because I'm making it weaker.
No, you are in that case, you are not making it weaker, you are just overusing.
Okay.
To stop.
So the tension of the muscles that are holding it in.
Yeah. Will be like the sign that you have. The way that addiction works is like you have your bladder and you have your pelvic floor on the bottom. Okay. So when the bladder contracts and when the bladder, it's actually when you pee, you should contract the bladder and relax your pelvic floor. Okay. But when your bladder is very, very stretched, it's exactly the opposite. The bladder is very, very stretched. Your pelvic floor is going to hold. Okay? But if you extend that much your bladder, then two things can happen. When you go to the toilet, it's not easy for you to relax the pelvic floor. Can be not. It's not like straightforward like that, but your pelvic floor maybe will not relax as should relax, and your bladder will not contract as should contract. And then you don't empty your bladder properly, for example.
Just because the bladder was too full at that moment.
Was
and
overstretched.
Overstretched.
And the pelvic floor is overworking, let's say. But it's not like you do it, everyone does it. Like, we have been all for this. Like,
I just had these moments.
No, I remember this in school. Like teachers were telling us, "Hold it, you are training it."
Exactly. That is so stupid.
You can swear as much as you like.
It's so stupid because we are just avoiding the input that we have from our brain. So this is not correct. This is not like. We don't choose the time that you need to go to the toilet. Why should I wait till the end of the class? Of course, kids overusing that time to go to the bar. We all know. But like,
teachers are not doing it to bully you, right?
Exactly. They do whatever they think.
Some of them. Hopefully.
Yeah. But it's more about the connection because the bladder are involved in the muscle, which is a detrusor. And these muscles is not controlled by your nervous system. It's your parasympathetic system. So you cannot control it. Okay? Actually, you can.
You can through the breathing.
Yeah, that's what I'm saying. Like when you have, in another case, another pathology that we used to work is an overflow, or like overactive bladder. Two different things. Overflow is what I talk about. Is like overflow. The bladder is overflow.
Overflood.
And then you have an overactive bladder, which is when the bladder is very, very active or hyperactive, and you just drink a little bit of water and the muscle around gets so stressed and like, I need to go to the toilet.
Okay.
And then you go and you just pee a little bit. Those are the people that's going like 10 or 12 or more than 12 times per day.
So that's the stimulus to pee is not actually coming from the amount of liquid in there, but it's just the whole system is dysregulated. Should be,
but in that case,
I mean.
no. It doesn't come from the amount of pee. Usually it doesn't come from the amount of pee, because then if you also don't empty your bladder completely, if you have any troubles to empty your bladder, like the case that I was talking about, of course you're going to drink a little bit and your bladder is overflow again. Because there was still pee there. Okay.
You didn't empty it.
You didn't empty it. It was full again. So two different things. You can have your bladder very full and not able to empty, and then you drink a little bit and you go 100 times, or you just pee and you just drink a little bit of water and you're going to pee, and then you drink a little bit and you do it again. In those cases, sometimes we advise so just sit on the couch and take some breath and see how is your pelvic floor, and if you still need to go to the toilet. This is one kind of training that we do. Those are the people that also, when they put the key on the door, when they reach home, they're like nervous system sending a message. You reach home, you need to go to the toilet. Or you know that you're going to travel, you're going to be 2 hours on the car, so let me empty my bladder before. So you are giving the extra stimulus to your bladder that is not needed. And
that is coming from, even stress?
Stress. We call the stress bladder, or overactive is more.
Overactive bladder.
Because overusing, which is not needed.
And then if you have a case that the bladder is kind of full, so it's giving you a stimulus to pee, but you, for dysfunction, can only get out a little bit, and then you drink again, there's a possibility of a lot of bacteria, right? Accumulation.
Yeah,
because the liquid is not supposed to stay there.
It's another thing that we usually advise to all the patient is not over in the toilet. Just sit all the time in the toilet. Even we have this misconception that when you go outside, don't sit on the toilet because they have so much bacteria. But actually, this is a myth. It's not true because...
Really?
Yes, if it's better to have tissues and clean toilet and put paper and do whatever you want, but sit. We used to say in Portuguese, sit your ass on the toilet.
I have something for this because the top of the toilet is made from material which is antibacterial. So bacteria are not staying on that. The same as the handles in metro or bus. It's not the same material, but they are made of material which is not holding the bacteria there.
Interesting.
And
Do
another
you know
thing,
how they do it?
it's the material.
I was like, okay, I'm a bacteria and I don't like this plastic, so...
Yes,
Okay.
something like that.
All right.
And another thing, like when you, that was a myth I was reading about. I don't know if it's true, but if you have a toilet paper, and it's like not covered in that thing, it's holding more bacteria from the environment. So if you are going to wipe it, you are
Gonna
putting
make it
even
worse.
more. Like,
Yeah,
So
maybe.
better to have your own tissues, let's say.
or if
that's
it's
why in the
covered,
public toilets they are covered by that
Yeah,
all
Yes.
part.
Yes.
Covered.
So
Okay.
maybe.
So yes, the coverage. So that's what I was reading about.
It's
Interesting.
interesting. Yeah, but that's the thing that we used to say, sit all the time, because when you squat, you are kind of contracting your glutes, contracting your quads, and you don't relax, so you don't empty your bladder.
Especially if it's not like deep squat, right? But
Exactly,
only half
exactly.
squat. Half
Like
squat in
usually in the
middle.
toilets, you don't. Most of the place you don't have the wall in the floor.
Yeah.
So, and sometimes even the toilets are high, so it's not easy.
But the most natural position is the deep squat.
Yeah, the
Yeah.
deep squat, especially for like the pooping and
But deep squat where you relax at the bottom. Like you actually like hang out there,
yeah,
right?
yeah.
Not
Not
holding
like
a
90
holding-
degrees. No, all the way down.
Yeah.
Other thing that I used to advise for everyone, and from the childhood till the eldest part, is like using the Squatty Pot around the toilet.
So the little stool.
The little stool. So when you put your toes, you are kind of squatting, and our rectum is not straight, so it's like a curve. And when you not like these, because here you also don't relax completely, because your back and your pelvis is totally forward, so you need to be here, but with the legs a little bit high.
So
Okay,
not
so-
resting the back.
So tilting the hips.
backwards and doing this, you are actually not doing anything, because your bump is like
You're closing
this.
it.
You are closing it, so it's too much. But if you put it like this and keep your back straight or bending forward, even bending forward is better, because you can relax your abdominal wall. We used to say it's the best position to
So
poop.
knees about the hip level,
A little bit higher.
a little bit higher, and kind of lean
Lean forward.
not tucked under.
No, exactly. So
Okay.
the angle that we have in the rectum usually gets more vertical, and it's easier to empty the bladder and the bowel, and also it's more. It's your pelvic floor is it's more relaxed in that position, so it's easier. Like parents, please don't put the kids when they don't touch the floor on our toilets.
Oh, just like,
It's like
legs hanging
over,
down.
Yeah. This is the worst thing, because that's why a lot of kids sometimes have constipation, because it's painful when they do that, and then they start avoiding to go to the toilet.
But also now just because we have a 3 and a 3.5-year-old niece. Tima has one niece, I have one niece. So we have 2 nieces together, and just watching them and having this experience of when they are sitting on that kind of big toilet, because they are doing it, but they never like sit straight. They always kind
Bend.
of close the chest towards the knees, right? So that's probably somehow they feel
It's more
natural.
comfortable. Yes, it's more
natural
comfortable for them. And it's too high. Like they don't relax completely. Like imagine you are sitting, try in the table very high.
And they actually
And
have to
you-
make sure they don't fall down, right? Because,
Exactly,
yeah.
because if they relax, they will fall down. So they are very tense.
Yeah.
They're like, ooh, should I? And yeah, that's when we have kids with constipation, it's like, stop. It's better to keep on the potty.
Okay.
And like for longer time than doing that.
So up to what age?
Depends of their height, to be
Okay.
honest. Or if they can go to the normal toilet, but if they have something to put the feet.
Okay, so that would be the recommendation, to make sure that they can relax their feet against something.
Yeah.
Okay.
Yeah. That's the main point. It's like, yeah.
Cool. So when
We just came around a lot of topics.
yeah, that's fine. We'll kind of just go wherever it takes us. Just one thing that came into my mind as you said about the shape of the rectum. Like the lesson from this is like your ass is not straight, so adjust to the shape.
Yeah.
As it is.
Usually it's like this. So
like
in
S.
that in that last point of the rectum is where we accumulate a lot of feces, and that's why sometimes we go to the toilet and we feel, oh, I'm not completely empty, because you are not able to relax and let it go completely.
And basically, you with your clients, you are teaching them all these theoretical things. So they increase the quality of the life.
Sometimes
through that.
it's enough, because I'm sad I didn't brought my pelvis, but like you actually have the bladder. Let's say this is the vagina and no, it's nothing there. So this is the vagina and the uterus here, and here you have the bladder, let's say, and here you have the rectum. Okay, so if the rectum is full as well, you're gonna press the bladder, because the vagina inside is like, it's not a tube, they're close together. Okay, if it's flat. So when the bowel is full, it's pressing the bladder. So you might have problems in terms of incontinence, or you might have problems like, I go to the toilet, whenever I drink a little bit of water, I need to go to the toilet, but actually it's not. The problem is not on the bladder, it's on the stool, because you are not empty, so you are not making space for the bladder to expand more.
Of course.
So we should never okay, it's urinary incontinence, let's look to the bladder, or let's look to the habits with the urinary. No, constipation is one of the huge problems around these. And then sometimes we can fix the constipation with pelvic floor exercise training, not strengthening, not relaxing, training. It's different.
We'll get there.
Sorry?
Yeah, I want to ask specifically about this.
But it's about habits, it's about food, it's about the amount of water. And then imagine you have a woman that, because of the going to the toilet a lot, she avoids to drink water. And then she's not helping the constipation and just make it worse.
Okay. So not really great loop.
No, we need to cut the cycle, and most of the times cutting the cycle comes from the constipation.
As you said, that the incontinency is sometimes, not always, sometimes also caused because of the food habits or whatever, right? Like that's the golden rule of physiotherapy. Never look at the problem where you see it. Like the root of the problem is usually, or many times, somewhere else.
Many factors, it's multifactorial. So
as a physiotherapist, you also have other kind of patients?
Yeah,
like just, I don't know, shoulder problems, hip problems.
Yeah, I do. At the moment, I do. And I have a lot with like lower back pain and hip pain. And when I get into that, I realize that there need some pelvic floor issues.
Okay, so anyway, whether it's your neck, she will find a way how to blame it on constipation.
Like actually jaw can be related, but mainly like hip pain and pelvis pain and lower back, it can be easily related with the pelvic floor.
Let's say, now I'm just making the sequence up.
Let's say someone that comes to me and say, I have pain since I gave birth, or I have pain since I was pregnant, and it was 5 years later and they still have pain.
Okay. So I'm just trying to think about certain possible sequence of how somebody can have a lower back pain from constipation, right? Because something is pushing on something, then muscles are getting tense, and then they overcompensate.
This is when it's hard to say like your lower back pain is because of constipation. Usually it's, again, multifactorial, but can be because of the constipation.
Can be related.
Can be because they have constipation or they have hemorrhoids since they gave birth and then they got constipated by that. Or can be because they have a heaviness or like something is hanging out on the pelvis and they have a prolapse, which is another thing that we used to work with. And there is no stability on the bottom and they come with lower back pain. Okay?
All right. So can you please explain a little bit more about core itself and role of pelvic floor importance within the core?
Yeah. So core is the word that I don't really enjoy.
You don't have to use it.
It's like
use whatever you want.
We don't have better now.
You don't have better now, that's true. But core is still like there is core, there is no core.
Core is a myth.
Exactly. We still don't know. But actually we know it's like there is a transverse abdominal and the multifidus and the pelvic floor and the diaphragm.
Okay, so
it's like a can.
I will just okay, can you break it down a little bit because you said a lot of words many people might not
so it's like a can.
Okay.
On the top you have the diaphragm, which is the main muscle for the breathing. On the bottom you have the pelvic floor, which is stabilizing the can, let's say, on the bottom. On the back we have the multifidus, so it's like a postural muscle, very small one and deep one on the back. And anterior we have a transverse abdominal,
which is not the six-pack muscle.
Which is not the six-pack
It's
muscle.
the one under it.
Exactly.
Cool.
And then what I was talking, so for me core it's this combination, it's this can. Okay.
I used to always think about it exact the same way. I just add the obliques on the side, but that's only because I'm obsessed with obliques.
Actually, I don't like it that much obliques. I try to avoid a little bit the contraction of the obliques when you have, for example, a diastasis.
Really?
Yeah.
Why?
Because there is some studies, it's very individual. I assess with the ultrasound when the obliques are actually working or when they are overusing and making the diastasis a little bit worse. Because ab separation more.
They are working more than the transverse.
And kind of hanging inside. And if there is no stability on the front, they make it a bulge. But this is not straightforward to everyone. Like I've seen women that they are overusing the obliques and they actually works better for them. And they actually can activate more the transverse and more the gap closes a little bit more. So really depends. And
have you been looking at the relation to lower abs then? Like under the abs, under the belly button part of it?
Usually pregnant women don't activate that part. Postnatal, especially
postnatal.
They so they are overusing obliques on the top and they don't use the ones on the down. So I teach them how sometimes we need to kind of deload the upper obliques and work a little bit down.
Because when I was dealing with a couple of ladies with incontinence, and I also have this from other coaches from our mentoring group, actually activating purposefully obliques in a combination with lower abs was getting them the control, which helped them to relax the 4-pack, the top of the 6-pack, and therefore it helped them, right? But also with
But it's not, that's my question is, I agree with you. That's why I'm doing it. Like I open up more the ribs and relax, deload the upper obliques, the upper 4-pack that you say. But how is the pelvic floor? Do you increase the internal abdominal pressure Do we not?
No, I mean, we do it through external pressure on there. So you either put fingers into the obliques and lower abs, and
No.
they're not flexing them in the meaning of like show off flex,
No.
but blowing it out.
Yeah, but imagine you have like a can.
Yeah.
When you press the can in the front, how is the button?
Well, you're supposed to focus on that as well.
But you don't actually, that's my question. Like sometimes they have, this is another thing that I was talking about. Pelvic floor sometimes is stuck. So it's like, imagine like a lift and it's stuck on the 5th floor. Mm-hmm. So if you don't deload also the pelvic floor, so if you don't relax the pelvic floor, you don't have range of motion. You might have activation, but not enough to give you this lifting. This is one of the functionals of the pelvic floor, which is the lifting the organs. So you might have the contraction, but not enough to lift your organs, not enough to work against to the internal abdominal pressure. Because when you activate the obliques, you are actually pressing down on the bottom.
Okay.
If the pelvic floor don't have this amount of lifting, that's the issue.
Okay, so 2 scenarios, right? A hyperactive and hypoactive or pelvic floor. Can you go more deeper into, well, pick one and then we'll pick the other one?
Yeah, so I used to say...
how it can occur, what are the reasons why it's happening, or what is the more likely scenario why it's happening, and what it means and what we need to do for that.
Yeah, so actually I look at the pelvic floor like a trampoline. So imagine if you have a trampoline very stretched, overstretched. When you jump on a trampoline, you don't jump that high because it doesn't have this flexibility. Okay, so you might jump, and if you jump a lot, you can't, for some reason, you can fall to the floor because you are jumping, and nothing happens. Okay, if you have the trampoline very loose as well, you jump on a trampoline, you go straight to the floor. Okay, so the pelvic floor the trampoline very loose. I would say it's the hypertonic pelvic floor. And the hypertonic pelvic floor, the pelvic floor very stretched, overstretched, it's a hypertonic pelvic floor. Okay? So both of them are not functional. They should have the flexibility enough to deload your impact and also put it up.
So bouncing,
basically. Okay? It's like a swing going up and down. So why? Because you jumping on the trampoline is the internal abdominal pressure. So when you increase the internal abdominal pressure with abs, with squats, with carrying something heavy, with sneezing, with cough.
On toilet as well, right?
On the toilet, you should not increase the abdominal pressure.
Oh, you should not increase. Okay.
There is ways to do it. It's not contracting the abdominal wall. It's more with the diaphragm. So it's more with the button.
Okay.
Which we call valsava. You know Valsava?
No.
It's like kind of...
Valsava. Valsava.
Like,
yeah,
it's a kind of breathing.
Yeah.
So it's one way to do it.
It's a lot of like pressure into head as well, right? Because Valsava breathing was also used for heavy lifting.
Yes.
Yeah.
And like that's another thing. We need to look individual. What's working for you? You know.
Okay.
I'm not like. For my practice and for we actually know so far is like there is no right way to breathe when you lift. There is no right way to squat in terms of breathing. I'm saying in terms of breathing because for you can work in one way, for me can work in another way.
Cool.
And that's why ultrasound is one of my main tools to assess. Because we can actually see in the ultrasound the count of and how much range of motion this pelvic floor has.
So do you do, when you put people on ultrasound, you tell them to do specific breathing or you tell them to...
Depends what's the issue. Sometimes we actually ask them to do certain movements, to engage the core, to activate obliques, to do some breathings, to contract the pelvic floor. And then I give the specific tip for that person. Okay. What I used to tell them is like, do this kind of exercise before your training to get more into that. Okay. Of course, and then when you put weight on, on our back. It's totally different when we are laying down on the floor or when we are standing. Okay, so we just need to kind of build up this progression from nothing to the training. But as much as you do it with nothing, it's starting to be more automatic while you are training, for example. And it's totally different when you are talking about someone who is doing a HIIT training when you are talking about a power lifter.
Yeah,
the weight,
sure. Yeah.
it's totally different. So the pelvic floor and the breathing, the technique should be different. So, oh no, squats, it's always like that. Breathe out down, breathe out in. When you go up, no. Some of my women, some of my moms work very well with apnea. So they breathe in, they stop, squat, and when I come up, they breathe out. Or they breathe in, they breathe out, they engage much better with more range of motion. And when they go down and go up, coming up, and they breathe again.
Do you also use the breath to determine range of motion for them?
Say again, breath to determine?
To determine range of motion?
No.
No? Okay. I'm just asking.
Explain.
Explain.
Yeah. And now I'm curious as well.
Julian was working on this in StrongFit, that basically you only go as far as you can breathe. Yeah?
Makes sense.
You can make inhale, you can make exhale, each for a little bit different purposes. But let's say to the depth of the squat, you do it with inhale and you go down. If the breath stops, you stop moving. You don't go past that. And if you do a couple of reps like that and you really follow the breathing, you usually find yourself increasing the range of motion, but not through the improper tension. So that's why I asked if you use that, because it's a very interesting tool, especially for beginners and people who are not used to train, because you don't need, or at least from my observation, we should not force people who are there first day, first week, maybe sometimes even first 10 years. It just depends on who it is, to go full range of motion just for the sake of the full range of motion. It's a great standard for whatever competition in powerlifting, CrossFit. But they are not ready. And if they can't breathe in that position comfortably, then they're not supposed to be there. And
sometimes they lose it as well. Yeah, it makes sense, because when they go at a certain point, they lose the contraction or they lose the position. So makes sense. Yeah.
Yeah. So somebody comes to you. I want to ask. So
it was clear the hypertonic and the hypertonic.
Well, we are getting there now. Okay. We'll go deeper and deeper. So on that sono, you ultrasound. You sometimes have them do specific, either breathing, whatever you determine you need to look at, and then you look at what is going on through that. Yeah. How does it work? They are doing push press, you said.
Yeah, sometimes.
How do you actually on them with the device as they're doing push press?
Yes.
Oh, that's cool. Okay. So you're chasing them around with the ultrasound.
I try to make it more and more and more. Depends also which kind of facilities you also have. But our ultrasound is portable, so we can make it around. And I do like push press, and at the same time I'm assessing the pelvic floor and how much is moving. Again, we still don't know exactly the beneficial for that. For me, it makes sense in the way that I use the ultrasound like a biofeedback. So when I figure out that it's more useful and it's helping a lot the patients when I ask them, see, this is what we want. Try to do it again with this, or this is what we don't want. And they can see on the display, and I explain them what is going on, and it's easier for them.
I've never heard of anything. Did you invented this method?
No. I was not into the ultrasound a lot, but actually it's very useful to see what's going on and what is activating and is not activating. I'm not sure still if then in the practice way they are able to, but I see difference especially between like transverse abdominal contraction, obliques, or pelvic floor, or breathing, I see it's easier for them to understand as well.
Mm-hmm.
Yeah.
Right. So, Celina, let's say how you get patients specifically for this. When somebody is coming with, let's say, incontinence, or in a clinic, they already know the ladies on the front desk. If they get a call that this kind of case, they refer specifically to you.
Yes, that's one of the points. Another point is like some doctors also advise, and mouth by mouth.
Okay, so
they're
references,
like friends and
happy clients. Refer to other.
Some colleagues as well. They also share, and I should say that the big part of my clients are postnatal or prenatal. So when the prenatal come, I always like inject the postnatal and the importance of the postnatal, so then they come over again. Yeah.
And somebody has post and prenatal at the same time, right? Because they're going for a second kid. So,
Yeah.
okay, when they come to you, and you know that there is definitely some pelvic floor problem, issue, challenge, whatever we call it, how do you assess? Is it more tense? Is it hypertonic? Is it hypotonic? How you assess the trampoline?
Yeah. So, as I explained before, habits are very important in the pelvic floor and pelvic health. But
what is important?
Habits.
Oh, habits. Okay, sorry.
It like has in all the parts of the physiotherapy, and sometimes we solve a lot of problems solving the habits. The kind of tips that I just explained to you. So we go through the history and then we assess laying down and standing up. Usually, I see how it works from outside, and then I do internal assessment when it's needed and when it's okay to do it. Doesn't mean that I'll have to do all the time. When the woman don't feel comfortable, I use some biofeedback, like the ultrasound is a very good tool to use in that case. But usually I do internal assessment because it's the only way to assess the muscles. Like you just see how the biceps are working if you look at that, if you touch there. If you don't touch, you don't really see.
So internal assessment?
Vaginal internal assessment.
Vaginal internal.
Or anal internal assessment.
Okay, you do that obviously
with my hands.
Yes, with your hands, gloves. And,
of course.
Yeah.
And like there is a lot, like some people when they heard that, okay, but when I go to the gyno, it's so painful, it's so bad. I don't go through that. Usually I don't work with pain. I find the points with pain, but I don't go deep into the pain.
And you do it all basically based on touch. Like you feel it, right?
Yeah, it's a little bit subjective, of course.
Okay, but I mean like you're not looking. Or?
Sometimes we have to.
Okay.
Sometimes we have to. So what I do basically is like touching, and it's not deep into the vagina. It's more into on the side and around the pelvis itself, because the muscles are there. One's more deeply and another one superficial. And the superficial one we can actually assess by just touching from outside and see how it works. And again, we just see how much the trampoline is moving if you watch that. If you don't watch, you don't exactly see.
When you know what to look for, right?
Exactly.
So you had some specific training in this manipulation?
Yeah, obviously. Yeah. It's a very specific, and it's not teached on the...
A lot of taboo around it as well, right?
Yeah, for sure.
Very sensitive. There are probably not many, definitely not in UAE, many guys doing this.
It's becoming more.
Yeah?
Yes, because when the men have issues, they look for everything.
Okay.
More than the woman, because the woman have issues, it's normal. The woman have pelvic floor.
No, I mean therapists, man.
Oh, therapist. No. So I don't know any therapist doing that as a man in UAE.
Okay, so...
Maybe I'm wrong, but I don't think so.
I will definitely get back into it later as well, but just a little bit now. When you do this for a man, you don't do men, you said.
I don't do mine.
You like you never done.
I never done. And I don't do it. I
Okay.
don't like
So
it. It's not kind of my interest. I know a little bit of the theory, but I don't do it.
But there it's done through the rectum, right?
Yeah. Yeah, and from outside as well.
Okay.
They can actually assess something from outside, but usually rectum and ultrasound as well. So,
Because I have a friend who I believe he was doing some kind of this, but I'm not sure if it was specifically for pelvic floor, but it was something with a tailbone manipulation, because that's also...
it's a coccydynia, which is another issue.
But that goes together as well.
Yeah, because actually the muscles around the coccyx are considered from the pelvic floor. So it's very, very, very usually. And the men struggle with another things like dysfunctional erectile and the urinary problems, also urinary and fecal incontinence, but also sexual problems, urinary problems, bowel problems, same, and lower back pain and this kind of stuff.
Is incontinence itself more rare in men than in ladies?
I don't actually know the prevalence, but I believe it's more in women just because the birth.
Okay.
Itself.
And maybe also the length of the urinary tube, right? Or is that a factor?
Maybe because of the neck of the bladder as well, but I would say more because of the birth, which is a big trauma for the pelvic floor.
Okay, so then, based on this, ladies before they gave a birth are way less likely to have problems than ladies after giving a birth. Natural birth.
Yes.
Birth.
Yes. Yeah? Yes, but it's not because you gave birth it's not because you didn't have babies or you were not pregnant at all that you don't have urinary problems or any pelvic floor issue.
Yeah, I understand that, but the birth is basically amplifying that a lot.
Yes.
So that's why it's very important to come before they want to be pregnant.
Yes, I agree.
And also, what do you think, or if you have any experience with fertility and like functional problems? Nothing around? No.
We don't have evidence base enough to say that we manipulate anything. But actually, if you have a woman that cannot either have penetration during the intercourse because it's painful, or we actually treat that. We actually treat symptoms as like endometriosis and painful periods. We go into the pelvic pain, but we cannot change the endometriosis. There is no way to do that. Pelvic floor, it's like same. Like if you have pain on the neck, let's say, all the muscles around will be tense, and we can work a little bit on this tension, but we don't treat endometriosis for sure, and we don't treat infertility. But if you are someone that you cannot have penetration or the sex is painful, yes, of course, this woman needs help, but we don't treat fertility itself. When we say that we work in pre-conception, it's more about working with this kind of things that you also should avoid to have a better pelvic floor, pelvic health in general, you know?
So there is no evidence that it can help, for example, for the endometriosis or PCOS.
What is endometriosis?
It's kind of pieces of endometrium, which is the side of the uterus that comes out to another organs.
Expansion.
Like expansion, yeah. Sometimes we find some clots on the intestine or on the rectum, around the ovary. And we also have endometriosis, which is another pathology that it's not that much taught because it's not easy to diagnose. And most of these kind of issues are diagnosed by surgeries. There is just a few exams that can assess them. but actually it's very, very, very.
And what is happening there? Why is
you
it
can have
happening?
hemorrhages, you can have very painful pelvic periods, for example, pelvic pain, constantly pelvic pain, or cycle pelvis pain, which is something that increase in certain times of your cycle period. So it's one of the big things that we
that's a symptoms, right?
Those are the symptoms.
Yeah, but what is the cause? Why is this? Oh, nobody knows. Okay, idiopathic.
Still,
okay. Still,
it's a very recent, not very, but it's recent that people.
And as it's hard,
was more aware about this.
As it's hard to detect, then it's probably less.
Yeah, because
studied
there
as
are
well.
4 phases for that, and just when from the first to the third is very easy to be normal. Okay, so it's very you are with your period, so that's fine, but when it's a phase 4, it's worse. And unfortunately, a lot of women lived with the grade 2 or 3rd for a long time, for a lot of years, and then certain time of our life increases to the grade 4 is when we figure out. And it's
what is actually happening at that moment in the whole system?
There is pelvic, there is pain, there is hemorrhages, there is...
no, I don't mean symptoms, but what is actually going on?
It's the endometrium getting bigger. And they spread it to all over the body.
Okay.
Which are you asking? Which phase that is going to the fourth?
No, just to put it very simple, because I still don't know what you're talking about. I understand.
Imagine
now I understand there are stages, and the first 3 you can't detect, but I still don't know what is.
So
happening.
You have the endometrium, which is the kind of, let's say, blood that comes inside the uterus, and when we have our period, this kind of blood comes out, and there is a regeneration of this file, let's say.
What was that?
It's some Portuguese.
We should have Amy here to translate.
So it kind of the wall of your uterus comes out, and then the new comes in. Okay.
Yes.
And sometimes the endometriosis is when this kind of wall comes out of the uterus. Okay. So. And
it stays
and can grow, and sometimes disappeared, and I still don't know exactly what's going on, because again, the phase 1 and phase 2, they are very small. And you don't really feel that much.
So it's basically I'm just trying to simplify it as much as I can.
Sorry, for me, sometimes it can be very easy, and it's difficult.
Yeah. So it's some residual particles, kind of that
blood,
of that inside part of the uterus.
That comes out.
That comes out, is not cleaned out as it's supposed to?
No, comes out but still inside. So instead of being inside of the uterus, it's on the wall from outside.
Okay, but where it's supposed to go normally? It's
inside,
supposed to go...
the inside of the uterus, and then comes out to the vagina.
Yeah, that's what I mean. This
is the period.
This is the period.
Exactly.
Yeah.
Exactly.
But some tiny parts stays in and starts to grow.
Yeah, but not inside.
Not inside,
outside.
But inside the system, but outside of uterus.
Yeah.
Okay,
and then ovaries, and then sometimes around the rectum itself. And but a lot of cases are founded because they have a cyst on the ovary, and then they do a laparoscopy. So they remove the cyst, and then when they remove, they figure out it's not a cyst, it's something. It's a blood. Okay. And they're like, what's going on here?
Right.
Or cases like infertility, they start to look at these, and they start to investigate, and they found out they are...
so it can be even kind of...
one of the
only
symptoms...
found accidentally when there's treatment.
A lot of cases, yes.
Oh, wow. That's completely new word.
It's a huge topic.
Yeah, huge topic. Okay, so you have your assessment, you can see, you can feel, maybe you use the ultrasound, and you determine whether it's the trampoline, it's too stiff, which means overactive, hypertense, or it's too loose,
Yeah.
underactive, hypotonic.
Yeah.
When it's hypertense, you obviously trying to relax it or teach them how to relax it. How is that done?
I just want to add one more thing. One of the
course.
things that I also use is it's a measuring between the urethra and the vagina and the rectum, which we call the GHPB, which is a measuring that determines how much the pelvic floor has the capacity or the ability to bulge. So how much the trampoline are able to stretch and how much is able to...
And that's from outside.
Outside.
You measure that from outside.
Yeah. This space between. And we know like certain centimeters are kind of overactive and another ones are like hypertonic.
There goes your math problems.
Exactly. Sorry. And then...
Good.
When we have a hypertonic, I do work a lot with breathing. I work a lot with positions. I try to understand why is hypertonic, what's going on there, what happened there. Sometimes it's psychology problem, sometimes it's trauma, sometimes it's something can happen on their life. And when I figure out, I don't try to solve them. I just refer them to outside, someone else. Because sometimes as much as you teach them, as much as you try to change their habits, body has memory. So
I once experienced, I was doing this course of self-protection and self-defense seminar for people with eye impairments, so blind people or people with a very severe defect on eyes, and especially one girl. It was you could kind of see this pattern on most of them, but especially one girl, and I believe she got blind when she was very young. So she was able to see before, but that for whatever reason, maybe an accident, I don't remember the reason, she got blind and we couldn't get her relax. But at all. Like this exercise, like give me your hand, and just relax. Yeah. And it would just stay. And she was like ready for fight constantly, traps like Tom Hardy, like just over tense, overactive, because she was always afraid of the environment, right?
Yes.
And there's just, as you said, like it might be psychological tension, right? Like at the end, it's always psychological.
Yeah. And we care everything in our body, like all our emotions are in our body. So we should not disconnect this part, because sometimes it's very, very important.
Mm-hmm. So sometimes you can see that straight away that, okay, well, I can do as much as I want to, but until there'll be this, whatever, trauma resolved or fear unlocked, whatever it is.
Sometimes I cannot do, I have pelvic floor that looks very hypertonic because it's the first assessment, but then the second one, it's easier.
Okay, because they relax more, they trust you more.
Yeah.
And then what if you really, really see that it's a really psychological thing? Is it your place to tell them, like, you should see a psychologist?
Yeah.
Or you don't tell them?
I tell them.
You tell them.
Someone I have to.
She's very straightforward.
No, I tell them. I don't tell them, like, you should see a psychologist,
you're a psycho,
like, what's going on.
Yeah.
It's not that way, but I try and I find a way for them to give me the reason to say, see.
Okay. So you just open the conversation and basically
I make them to tell me that they need to see a psychologist, right?
All right. So, okay. Mind games. Yeah.
No, it's like,
yeah.
Just show them,
Yeah.
there is no, I can ask a few questions, but like we all need help. Why it's so easy to find physical help and it's not easy to find mental health?
When we talk about hypotonic, it would be hyper, too much tension, more likely to be from mental stress and so on. And then the hypotonic is more about strengthening and actually dealing with that physical part of it, or that can also be because of the psychological?
From my experience, I can say yes. Psychological gives you stress, especially the stress and the alert. Your body gets more tense, right? For any reason. But hypotonic, I cannot go straight for like that. But yes, maybe I can say it's more psychological stress gave you more hypertonic. But if you have a very depressed, I can imagine a very depressed woman. I have some on my head that they just disconnect with their body completely. So yeah, they need to strengthen, but they also need help because they just gave birth, and from the head to the hip, they don't look at, they don't touch. They are very, very disconnected.
Oh, like psychologically, you mean?
And physically, they don't accept their bodies, mind-body connection, you know? So, yeah, they can still have a hypotonic, but have mental issues, so...
Because you just gave me an amazing idea now. Again, Julian from StrongFit, he came with a lot of very cool stuff. He got it from Dr. Purge as a phylogenetic hierarchy, which is all 4 mind states. You have flow, fight, flight, and freeze.
Flight and freeze.
Freeze, yeah. Flow and freeze are parasympathetic because that's more passive, or we would say relaxed, but it's not really relaxed because when you're in freeze, you're definitely not relaxed, but it's passive. And then you have fight and flight, which are the active part. That's sympathetic. However, they are not the same because it's very different to be the hunter or to be the prey, right? So fight and flight are very different, even though they are both on the sympathetic. And when you said the hypertonic people tends to be the more tense, anxiety, so on. But then you said that you have a specific case in mind where this lady has hypotonic, but it's also psychological, but it's more towards depression. And this is exactly what he is very much separating, that the depression is on the parasympathetic side, where we give up on our why, our intention to live, produce anything.
Yeah.
And then on the sympathetic side, overdrive on the sympathetic side, and especially flight, is the anxiety. So like, I just like have this concept now. Hypertonic would be more towards anxiety, and hypotonic would be more towards depression, even in the regard of muscle tension and pelvic floor.
Yeah, but doesn't mean that like the hypotonic, if they solve their depression, they will solve their pelvic floor, which is in the hypertonic. If they solve their anxiety, or if they can manage better their stress, sometimes works better on the pelvic floor.
However, I absolutely understand what you're saying, and I completely agree. However, the first step for people who are in depression to actually even do something about that pelvic floor is to get them out of the depression, right? Because if they're kind of passive towards it and they don't really care because they are in a depression, they're not going to work on it.
Well,
it's very simplified.
Yes. Sometimes I'm very into the depression, but I have physical issues. When I teach them, you need to do this kind of exercise every day. They really want to change that because they impact their lifestyle and their life quality, and they can improve from the pelvic floor and still have depression.
Okay, got it.
You know, of course, make it easier if you are better in all the ways, but I cannot say if you don't solve your depression, you will never improve your pelvic floor.
I didn't mean it that way. I'm just
on the extreme. But yes, of course, it's related. We cannot separate mind for body. But they need a lot of patients need help. Physical
But
way.
that's why they're there, right? Physical and mental.
Yeah, mental. Yeah.
Did you get any psychological training in your school, in your studies?
No, like we have a lot on the physiotherapy degree. I think I had like 7 or 8 psychologists, but I think it's a lack in our course to know and to teach them how we deal with that, because it's easy to figure out, but in some cases that we don't actually know. We don't know exactly what we should say, how you should approach the clients. As I explained, I was one of my passions since I'm childhood. So I like that, and I learn a little bit, but I'm not expert, and I fail a lot, of course, because it's not my kind of.
So you think the psychology training would definitely help if you have some more?
Yeah. Psychology or any kind of therapy, more mind therapy, will help all the healthcare professionals. I think so. I don't know if you agree with me, but at least communication. I think
anybody who is dealing with people,
exactly,
and that's pretty much everybody. Even
but at least communication. I think we should know how we should approach and how we should approach them in a better way.
We have a lot of experience also as a coaches. Sometimes people, they are not even training, they are just talking with us.
Yeah, you have a couple of people who will come, and it's like, it's a therapy. You just listen, nod along, sometimes offer, your perspective.
I would pay a coach to train with me just to talk, because it's so boring.
Okay.
Like no, I'm the kind of I hate to train by myself, so I would pay someone to come with me to the gym just to be there.
And then you have people who talk because they want more rest between the sets, and they always hook me on that, because they know if they will give me some question about physiology, movement, whatever, I will just start to go, and I was like, motherfuckers, got me again. I start to talk and explain, and they know how to play me sometimes. Yeah. Celina,
so if you are looking for somebody
to help me,
if you're looking for somebody for chat and training, or training and chat, the ratio depends on agreements. Please tell me, when you have somebody with hypotonic, what are the exercises? How you strengthen it? How you go to
contracting the simple thing is like doing the famous Kegels, or like the contraction. I don't like to call them Kegels, because Kegels were the guy that invented in 19 very early, was very old school.
90 something.
But I don't even, it was very old school, like 1950 something.
Okay, can you explain exactly what that is?
It's a contraction on the pelvic floor, and you usually have 2 kind of contractions, which is a fast contraction and relax at the same time, and you have the endurance, which is a contraction and hold it a little bit.
And that's a method.
That's 2 kind of contractions, let's say. It's the same with the biceps. You do bigger contraction and you contract and hold the weight on your
Okay,
hands.
so basically you do concentric, eccentric, or concentric, and then you do some iso hold.
Yes.
With the pelvic floor.
Yes. Sometimes we need to do eccentric.
You do eccentric. How you do eccentric with the pelvic
With the breathing. Like
with the exhale.
With the inhale. So
okay, tell me.
With the
I really want to know this. And so, before you go into it, can guys do this as well? Can, right?
Yes.
There's just muscle contraction in the pelvic floor.
Yeah. So again, they can. Okay, so if you breathe in, what's happening with your diaphragm is going down, right? So your pelvic floor, the bottom of the can also should go down, right? So when you breathe in and ask the contraction, you actually are working on the centric.
Okay.
And then let it go, for example. Mm-hmm. Or doing the Valsalva, which is going to breathe in, stop breathing, and do contraction.
Okay.
Or contract, hold, and then you cough and keep the contraction, or you cough, you breathe out, slowly, and you relax. So you are working on the eccentric. Really depends on when the leakage happen, which kind of leakage, if it's pee or poop, if it happens during the exercise, if it happens after the exercise, because it's not only when they do exercise. Sometimes when they are doing exercise, the pelvic floor is working there, but then as soon as they stop, they're like, phew.
I have more experience with, like ladies through the class, just like, I need to go to toilet, and it's because there is jumping.
Yeah.
Either box jumps or
so in the jumps, I could say
skipping rope.
It's more the fast contraction.
Uh-huh.
But again, why I feel itching when I heard some coaches teaching them to do that, because you don't know if they need it.
Oh, you mean like coaches are saying them to, as
Like
they
in
jump,
postnatal,
to contract?
no, in postnatal classes, for example.
Uh-huh.
So they are doing glute bridge, and now contract and relax, contract and relax, contract and relax. For some of them might be good, but some of them maybe not.
Might actually make it worse, right?
Make it worse, because you are overused. You have a hypertonic pelvic floor. If you keep contracting there, it's not worth it.
Can somebody determine by self-assessment at home? Like now some ladies are like, well, I have urge to pee when I jump a rope, or I have urge to pee when I lift, or Tima showed me some insane video a couple of days ago.
Celina was sharing it.
Yeah, so the lady, it was deadlift, right?
Powerlifter, yeah.
Sumo deadlift, I believe,
Yeah.
right?
It was a sumo deadlift.
Sumo deadlift, right? And woof, there was a lot of liquid. Wow. Okay. Anyway,
in that case, I think
gates
it's
open, fully wide. Yeah.
In that case, I don't think she's hypotonic, because she's strong.
Okay, so you think the leakage is because there's so much tension going on,
and there is no lifting to close the neck of the urethra. Okay, one of the function of the pelvic floor is the lifting to close, so they can stop, but then they need to kind of twist. And when you increase the abdominal pressure, which is when they lift, it opens up and there is urinary incontinence. So sometimes in that case, you need to deload the pelvic floor to gain the range of motion, and then we need to work on the strengthening.
Yeah. So it's not basically that simple, like, okay, relax if you're hypertonic, or strengthen if you hypotonic. It's just the whole mechanism of like the whole body, super complex.
Exactly, it's biomechanical,
Wow. Okay, so self-assessment, is it possible? Is it not possible? Or can you give a free 5-minute manual to ladies how to assess it, or even to guys?
I don't think so. It's
Okay.
easy, especially because of the position. They can guess more or less how they are if they feel when they contract, they actually are able to relax and have they can feel the range of motion. Like for me, it's easy because I'm in this file, so I know what I'm doing right and what I'm doing wrong, but I don't know. I don't think it's clear for women to do that by themselves.
So now, basically, I don't want this to sound rude, but without fingers in, they can't assess it at all.
They can do it with the mirror, for example.
With who?
With a mirror.
Oh, mirror.
If
Okay.
they can see movement on the pelvic floor, so the space between the anal part and the vagina, if they going inside or outside, if they just go a little bit, because you can see the contraction from outside. Exactly, and to be accurate, if they are overusing more the superficial or the deep muscles, I don't think they are able to, but at least they can see if they have lifting, if they are able to hold it, because when you are contracting the pelvic floor and you lose it, you will see on the mirror that you kind of miss it,
Okay.
So they might have more or less the knowledge. And then if they have pain during the intercourse, if they have constipation, if they used to lift weights.
Yeah, I mean, just generally estimating which it is, hyper or hypotonic.
But there are also some tools, no? Like kind of massaging or the some balloons or I don't know.
No. It's not that accurate to self-assess.
Okay.
I would say they should feel both of phases, relaxing and contraction. If they don't feel some of them, they should look for help. Let's say.
Okay, yeah, so that because that's also coming to the muscle-mind connection, right? So
Yes.
if you can't feel change for
Sometimes,
shit, because
exactly.
Yeah.
Sometimes they are thinking they are working the pelvic floor, and actually they are jumping on the chair, and this is glutes.
Okay.
Or they are doing this with the legs inside, and this is adductor, and nothing goes down there. Or they are doing with the abs and nothing on the pelvic floor. We actually know the postpartum, especially the postpartum, because again they disconnect with the chest lower. 60% of the women, they don't do it properly.
Wow.
So it's a huge amount. And we need to start giving this education in the with teenagers. We need to change the habits. And once you change the habits, we change also the health on the pelvic floor, and they will not reach the 20s in the very bad condition. And they will probably be better when they give birth. So we need to talk about this very, very early. They need to know what's going on. Like, if you ask, I don't know the numbers, but maybe ask 60% of the women, they never put the mirror and they never know what's going on there.
I mean,
to see each other.
even now when you said that, I was like, oh wow, like
Mirror.
this isn't a thing, you know? Like,
But actually, it's like, it's part of your body. It's like, if you live with a hand behind your back, you will never know how is your hand.
that's very true.
So you need to look at.
Simple logic.
So it's the only way to connect with the hand and to know what's going on. And there is a lot of also statics that we should look the same. Like even with the breast, we should look the same. We have, this is the way that we see in the books. And when you look at you, oh my God, I'm not like that. Yeah, we are not all the same. We are different. We have different shapes. And it's good to know what's going on with you. Even like how and why we see our moles and our skin. And sometimes like cancer in the vulva is more common than we think it is. So if you never look at the days that you are looking, is like, you think it's normal. And then you have a
Yeah, because
mole
you have
there.
no comparison.
Because there is no comparison, so...
When I followed this lady, and she's talking about this. She's doing some of these exercises. What is the breathing exercise she's doing with the belly? You do it as well. The vacuum.
Vacuum, but with the movement.
Yeah, so like
massaging the organs.
Yeah, so like creating the vacuum and massaging the organs,
yeah.
and she's also doing a lot of work on her pelvic floor. She was saying, well, there is a lot what I can share from her, but is this whole practice also increasing the quality of sexual intercourse? It is, like increasing the sensitivity of the vagina. No?
Scientific way, I don't know anything about this.
Okay. So you can't because that's her. Maybe it's a selling point. I don't want to be. Maybe it's a selling point that she's trying to.
That's for why I'm aware. There is no connection between hypopressives, which is this kind of exercise, and sensibility on the vagina. But I don't know everything.
But maybe from the point if the intercourse is painful.
If they work in the pelvic floor, they will never have a better intercourse. But like, again, if you are not aware and if you're becoming to be more aware and look at these and working and contracting and relaxing, you might feel better during the intercourse.
Okay.
I don't know.
Okay.
I don't know. I don't know which kind of exercise she does.
Well, that's what I will. That's what I'll tell you now. So she is doing. I don't know if she created it. I don't think she created it, but she's doing also with, as you were saying, like contract release. She's talking about hypertonic differences and like get assessed and all that. But also she is doing for her personal challenge a weightlifting with vagina. So she will get this yoni egg, is it?
Yoni, yeah.
Yoni egg with a little string on it. She'll insert it in, put a weight on that string, and like hold in, walk around. Apparently there is a world record in this, which is 31 pounds, which I learned. I don't know if they go like, you have to hold for 30 seconds. I don't know what the discipline actually is or looks like, but that's a little bit
Maybe
extreme,
she
right?
needs to really do that because she wants to compete.
Oh, maybe, I don't know.
She needs that for what? Like, there is another way to strengthen the pelvic floor before I didn't finish, which is with weights. So, for example...
Yeah, go on.
Sorry. There is... what I want to say? I forgot. There is a way to assess the strength, the pelvic floor, which is with cones, yes, with like small eggs, also with weights. Okay, women that they go for a walk and after a while they start to feel heaviness, or they start to feel after the running they have the urinary incontinence. Sometimes I have advised some hags, some women, where they can, I cannot do the exercise, for example. Like, I'm very busy, postnatal, they have so much things to do, they focus on the babies, but every day I go for a walk. Okay, so use the egg with some weights, put it inside, and try to keep it while you go for a walk. What we are doing, working on endurance. Okay, that's...
And how do you attach a weight? No,
it's like a small egg that you open and have like a small weights.
Oh, so it's inside the egg. So
Inside
the egg
egg.
itself
it's like
has...
a tampon.
Okay.
But they can increase the weight in the tampon, let's say. And some of them, they have different weights itself. So every egg has different weights. So we are working on endurance. So when they keep the contraction there, they are working on endurance. I'm not against you, but we need to look at why and what's the purpose. Okay.
I think she's a coach, and she went through a lot of transformation herself, and this kind of pelvic floor exercises was one of the things that she benefited a lot from. Timmy, can you give her water?
Thank you. I didn't drink from this one. Thank you.
So when she benefited from that a lot, which means that she now is trying to also give her client similar experience. She said that she doesn't recommend anybody to do the actual weightlifting and so on. You know, she posted this video with this skirt and kettlebell hanging, but she's not like pushing it on other people. She's just showing it that that's also possible. But first start with these tiny steps that I went through a couple of years ago, and it got me here. I just found it very out of anything I would ever imagine I will see. the loading.
Yeah, if someone comes to me and said, I want to enter in that competition, that tournament, okay, let's go. Training the pelvic floor at another muscle, if it's healthy, I don't know.
Because the only way I can imagine guys doing it is putting it through their ass, right? And trying to hold it in. But
I don't want to imagine how is it.
I don't. Yeah, you
I
probably,
hope they don't come to me and wanted to be trained for that. As a man, as a woman, because I would not be able to hide my face. Like, what?
you will have a special athlete division.
Like,
you know.
I think I'm going to refer to a colleague. Yeah, there is nothing to say. There is no scientific way to say, studies to say this is wrong. So we still don't know if it's wrong or right, but I would not advise, and don't expect to do that.
It's not necessary, right?
Exactly. That's the thing. Why she's doing that? What is the, but my husband runs ultramarathons. Why?
Yeah, well, that's a very good question. I want to actually ask him as well. What sport do you do?
I do.
How do you
I
train?
go to the gym and I do normal, and I do aerials, which is hoop
Aerials.
and
Aerials?
Yes,
hoop and silk.
Yeah.
Oh, like the acrobacy.
Yeah.
Oh wow, okay. It's like a pole dancing, but with the
silk.
The silk. Okay. Yeah. Cool. Do you have any message for people, for ladies, or do you have anything you want to add now, like what we didn't cover?
To add, I don't think so. It might be a bit confuse some parts. So if it is, just message me and do any question. I try to explain better. And I just want to add that we don't have all problems, but as much as we know about ourselves, better for us. So I don't want now to pass the message that everyone has pelvic issues. That's not true. It's about habits, and if it's an issue for you, I think you should look at. But if not, just live your life and be more aware about yourself.
But generally, we have also, we can't say everybody has a muscle imbalances, but we know that everybody has some muscle imbalances. Like, nobody is 100%.
But what's the problem
correct.
to have muscle imbalance?
Yeah, I think is his point. What's the problem to have muscle disbalances? No,
Yeah, well,
if you don't have any particular problem, then it's not the problem. Also, so maybe it's not normal that if you have some leakage or if you feel like to pee during the training, especially with some specific movement, jumping and anything, it's not normal to have it.
Yeah. Yeah, it's not normal.
Yeah, but it's very common.
Yeah,
It's
very
it's a
common.
big deal, especially with people really pushing the limits on.
Yeah. As everything, it's sometimes I have women that comes to me and they can do everything that cannot jump, and they avoid jumping forever because they know they're gonna pee. So what we do, instead of jumping on the rope, we start with jumping in another positions. It's gradual exposure to the movement always. If you go straight forward for the run, if you go straight forward for the jumping, doesn't mean that you cannot do anything else. You can still do, but step by step, you need to gradually increase and explore the movement. As another part of another kind of training. I think you all agree with that. If you have someone that comes to you and I never trained in my life, so you will put 100 kgs on her back and ask for or you might do it, but then no, I'm saying you might.
You can do whatever you want. You just have to count with the consequences.
That's a thing. And then you come and maybe he's able to make it. And you say, oh, you are strong, but what's the consequence? We don't know.
Yeah.
So,
and another thing, when they have pelvic floor problems with the jumping, they will find a pattern to protect, and they will change the movement pattern not only for the jumping but for another movements.
In the different muscles, you mean?
Yes, in the big muscle groups, not only inside but outside, and you can see the pattern with the lunges, for example, they are going too much together.
Yes. Same with then they come to you. That's the case that sometimes they come to you with pubalgia, or pubalgia is a pain in the pubis, groin pain, or let's say lower back pain.
Because of the protection.
The protection and
Okay, so
they are
so they
overcompensating.
like tuck the hip the opposite direction to
Or
keep it
inside, or
yeah.
like. So there are so many things can happen. And when you look to the picture from outside and there's something else.
Okay, now I basically know what your answer will be, but I will ask anyway because you can go a little bit deeper into it. What is the common time frame you can actually help people to have some significant change?
What do you mean about
Like
for
when
how
they come to you, how quickly they will improve? It depends. That's the answer, of course. Okay.
depends of the.
Okay, but is it probably not to 1 week?
I had improvements in 1 week.
There you go. Okay.
Like I have in my mind one CrossFitter. She used to work out a lot, and when she came to me, it was after birth. Like I just want to see if everything is doing well. And the next week when she came, I told her like, look, you need to come twice a week because the way that I'm seeing now, I'm a little bit worried, and now it's a perfect time to fight against it. And when she came the next time, I was like, what the hell? Like, what you did? Like, I might being assessing in the wrong way in the beginning, or maybe she improved that much because she was that worried like me. And when I look at like, congratulations, you did a very good job. So in 3 sessions, she was done.
Nice.
It really depends the effort that you put outside, the severity of the consequence, and
so obviously you giving them homework to do.
Always.
And always. Okay. Are they good at following homework? But you can tell, right, if they did the homework or not.
Sometimes, yes.
You can see it.
Yes. Sometimes see. Yes, but it's one of the hardest parts because doing pelvic floor exercise can be very boring. I try to make it like, as I explained before, the cones are one of the ways that I used to use when they are very busy and when they cannot do it in another way. Okay, so at least in that 30 minutes we are doing something, so use them. I try to include as much as I can as a routine to make it less boring. We also have an app which is from UK. Not everyone can use it, but it's like the app called Sneezing. And we sometimes use the app like to follow. I try to be more interactive as I can, but sometimes like there is no way to work pelvic floor if you don't do that. So yeah.
When these ladies are kind of like practicing and training on their own, like you obviously like ask for feedback, right? So what are you looking for in that feedback?
When they train on their own, how do you...
Like you give them the homework.
Yeah.
And then you ask them, so did you do it? They say yes, no. And then you ask, how was it? What are you looking for?
I was like, if it was easy for them, if there is something that I can change in terms of the exercise, if they could do it, how many times they did it, it was worth it, was not worth it.
Okay.
Like when I ask that, it's more, did it help? Did it change something on your daily basis? It's more about that. I'm just having so many random questions now.
Is it possible to do the exercise of like, you can find it online a lot, like self-exercise, just like when you're on a toilet, stop the flow?
No, don't do that.
So that's a no?
No. So actually when you do that, it's not healthy for you because you can do it once in your life to know how is the pelvic floor contraction, but you don't need to. Because there are other ways to do it, like with a mirror or with the finger between the anal part and the vaginal wall, and you feel the contraction there. And actually when you stop your flow when you are in the toilet, you can have a reflux of urine that around the urethra and goes inside again. And the urethra sometimes has bacteria. So you just kind of pull these bacteria to your bladder, and that's when we have urinary infections.
Okay, good. I'm glad I asked this. Okay. Well, it's a common advice you can find,
Yes,
so.
especially for men, the urethra is bigger, so.
Men do it a lot?
No, I'm saying especially for men, I would never advise
It's
them.
even worse for them. Okay. So, as an assessment once in life, maybe, but even that is not necessary. Okay. Cool. Celina, thank you very, very much.
My pleasure.
And
it was a pleasure to be here.
Hopefully we'll have you some other time on maybe some other topic as well.
Yeah.
Thank you.
Are interested in something else, let me know.
Of course.
Thank you. Thank you, Timmy.
Thank you, Timmy.
Thank you.